Good afternoon, everyone. I will talk about using interpositional bone grafts to treat the posterior mandibular atrophy. The atrophy of the posterior mandible can be solved in a number of ways. But the first point to make clear is that no one technique is the best. No one technique is the best. Why? For all these reasons, there is no scientific evidence that one technique is more predictable than another. The test is that everyone proposed the technique they know best. The treatment plan will depend on your training and experience. I use the interpositional bone graft technique to treat the atrophy in the posterior mandible. What is the interpositional bone graft technique? It is called the sandwich technique or inlay technique. The procedure involves the vertical lift with a bone segment and the insertion of the graft between the basal bone and the osteotomy segment. How is the inlay technique performed? First, we do a total thickness incision, followed by osteotomy of the transport segment. In particular, 2 vertical and 1 horizontal osteotomies, paying attention to the lingual periosteum. The segment obtained is raised vertically. This video gives a good idea. The first thing to do is to decide where to make the total thickness incision with our scalpel. The height of the vestibular incision will depend on the position of the mental nerve. After making the incision, we expose the area and isolated the mental nerve. Now, with the piezo, we draw the osteotomy lines. 2 vertical, this is the mesial osteotomy and the distal, and then to rule the segment, I use an ordinary curved dental extraction lever. At this point, in the space obtained, the material is positioned. Then, fix everything, because at the end, it is needed to stabilizing everything with the titanium mini plates. And lastly, covered with a resorbable membrane. When can inlay be used and when it is not possible? I use the inlay technique for vertical defects. Vertical defect, that is the crests with adequate residual bone thickness but insufficient height for implant placement. I don't use this technique for horizontal defects, and I will explain why. But the important question is how much residual crestal bone does the inlay technique need? The inlay technique in the posterior mandible requires a residual bone height above the mandibular canal of at least 4 millimeters. Below 4 millimeters, this technique doesn't work. In my hand, doesn't work, and you understand why. This slide is what I think about when to do this technique or not. I have performed the inlay technique for more than 10 years, and we started with autologous bone grafts, in particular iliac crest bone block. And this slide shows the first patient we treated with the inlay procedure back in the 1990s. I was still a student. And note the clinical lack of the bone in the posterior mandible. And this is confirmed by the CT scan. We performed the inlay technique on 6 patients using a block of the iliac crest bone. After 2 weeks, the vertical increase is clinically evident. And then rehabilitation with definitive crown. At this point, we compare the inlay technique with other techniques we have used to treat posterior mandibular atrophy. The onlay technique, for example. In this study, the control group had onlay, while the test group underwent the inlay. And when we started to see some advantages, in particular in terms of the predictable graft and stability. And if you look here, this is the onlay technique. I have 2.75 millimeter to vertical bone resorption versus the inlay group, which I have 0.5 millimeter. We also compare inlay with alveolar osteodistraction, and the study is the same. Our results with alveolar osteodistraction are not very good. If you look here, we have 16% of the complication. We prefer the inlay technique because in the end, it is only a fast type of the alveolar osteodistraction. Dear colleagues, what did we learn from this first experience? These studies started to show the potential of the inlay technique compared to other surgical techniques. To ensure the success of these techniques, we devised some rules and guidelines. We learned, the first point is, we learned it is important to create a coronal segment, this part, with adequate thickness, at least 2 millimeters. We also found the success of the inlay technique mainly depends on the stretching of the lingual periosteum. In particular, after making the 2 vertical and 1 horizontal osteotomy, I carefully stretch the lingual periosteum to move up coronal segment, like this video. In these conditions, the bone block will receive its first vascularization from the lingual periosteum here. That in turn will vascularize the coronal segment, like in this area. But the bone block also receives a second vascularization from the residual bone vessels above the alveolar canal. At the end, my block in the inlay technique receive this first vascularization from the lingual periosteum and the second vascularization from the residual bone above the alveolar canal. You can see how the bone block is better protected from that in, for example, other technique like onlay technique or GBR technique, like in this picture, or any other reconstructive technique in which a bone block or particulate graft is inserted above and not in between. Remember, dear colleagues, we are treating atrophy of the posterior mandible. This is why I prefer to use the inlay technique in the posterior mandible, because in this case, the graft heals more quickly. It is more protected, and after 4 months, we inserted the implants. You can see this probably explains predictability and stability of the graft after 10 years, and implant stability after, again, 10 years. But for all this to work, we need a rigid fixation of the graft material to prevent micro-rotation. The message is fix your blocks, as you can see in this video. This is the university where I work and the city I live in. It is one of the oldest universities in the world, founded in 1088. But Bologna is not just the university, it is a beautiful city. And if you come to Bologna at the weekend, you can find me here with my friends, enjoying good food and a glass of wine. Now, seeing the potential of the inlay technique, our aim is to improve it, to make it simple, safer, and reproducible for all operators. What does this mean? When I started the technique, I was carried out with traditional instruments. Today, I use piezosurgery, and this has made the technique easier to perform and less traumatic for the patient. The second aim was to see if autologous bone could be replaced by heterologous bone in the inlay technique. This meant less discomfort for the patient, lower costs, and easy technique to perform under local anesthesia. But analyzing the literature of heterologous and homologous bone block using only technique to treat the posterior mandibular atrophy, the results are not encouraging. As in this study, comparing the efficacy of heterologous bone blocks with autologous bone blocks in atrophic patients, the test group had the heterologous bone block while the control had homologous bone. These were the centers, and we enrolled 40 patients, 20 in the test group and 20 in the control group. In the mandible, it was a disaster. We suspend recruitment because all of them failed. If you look this video, this case is very difficult, is very atrophy in the posterior mandible. And in this case, you know, I prepare the block before the surgery. I prepare the mucosa before the surgery and prepare the site. And then I fix everything. I fix the blocks. And the end, I close the gap with particulate, and I cover everything with the membrane, and I fix the membrane. All the steps, the intervention were, I think, that it's my opinion, correct. And look, it's closed everything. And the look, radiographic imaging, show a good vertical bone increase. And after healing is a perfect soft tissue. But the CT scan shows something is wrong despite waiting after 7 months. And look in this video, the block is the same block 7 months ago, but in this case, the block is red. Here is a better view, but the question is, what will happen to the implants placed? We continue to lose implants, and the final solution at the moment is short implants. The same results were obtained using block of allogenic bone, in particular 18.5 more failures than autologous bone. Even if we reconstruct over time, the outcome using only technique to treat posterior mandible, in this case with allogenic bone, is unpredictable. Now, what happens if we use heterologous bone block using interpositional bone grafts to treat the posterior mandibular atrophy? We designed a randomized controlled clinical trial to test an organic bovine bone with iliac crest as a control. The main aim was to see if autologous bone, especially iliac bone crest block, could be placed by heterologous bone in the inlay technique. In this study, Bologna University Ethical Committee approved the trial. These are the inclusion criteria, and note how the surgical technique is the same, but here we use a block of anorganic bovine bone, like this, covered with a resorbable collagen membrane. The table shows the first important clinical finding. The vertical increase where biomaterial is the similar that obtained with iliac crest. On reopening the mandible, we send sample for histomorphometric analysis. I'm not a histologist, but we can see in the pink a new bone surrounded by biomaterials. Looking at peri-implant bone livers, bone loss differences between the two groups were not significant. In conclusion, our results show both bone augmentation procedure had good outcome, but an organic bovine bone was less invasive. We still wanted to improve because the most important aspect that has the impact of the results of the inlay technique is the type of the block. Why? Look at this video. Look at the fragility of the anorganic bovine bone block. And this fragility leads to a loss of the vertical increase. So we examined other solution and we changed the type of the block. We tried heterologous collagenate bone block, and now you will see why we have actually no problems with this type of the block. This is the same case as in the video, treated with heterologous collagenate bone block, and on reopening after 3 months, and the implant placement, the rehabilitation, and look at the histological spacement. Look how easy is it to insert this material, this rigid material. Another example in the posterior mandible. Look at this other case. In this case, we have atrophy in the posterior mandible. Clinical posterior atrophy on the right. We do the inlay technique, the same technique, 2 vertical, horizontal, and 1 2 vertical and 1 horizontal osteotomies, rising the transport segment and using a collagenated cancerous equine bone block. We position it and look at the good increase. Dear colleagues, considering we are in the posterior mandible. In this case, you have maybe 8 millimeters. We fill the gaps with particulate, and at the end I cover with reabsorbent membrane and suture. The OPT after surgery and the clinical view after healing. Before and after. After 3 months reopening and implant placement. Bone core sample, look at the quality of the bone. X-ray after surgery. The situation after 3 months. Provisional rehabilitation after 3 months, after 3-4 months. Before and after the surgery and the rehabilitation. 1 year later and 3 years later. This technique also works in the superior maxilla, like this case. Here we see an opening after 3 months. The bone block is not visible. And in this picture, you understand what I mean. Before and after. We collect all the inlay procedure done in the past 10 years, and our patient have this characteristic, only atrophic posterior mandible. These are the material we compare. And these are the intervention and the patient. More than 120 inlay procedures. And we analyzed 256 implants. This is a case with autologous bone block from the iliac crest. And this is the same case after 7 years. A case with a block of heterologous bovine bone block with the provisional prosthesis, and after 5 years. We collect all the inlay procedure done in the past years. Our patients have this characteristic, atrophic posterior mandible. These are the material we compare: autogenous iliac crest block of deproteinized bovine bone mineral, and collagenated cancerous equine bone blocks. These are the intervention in the patients, more than 120 inlay procedures, and we analyzed 256 implants. This is a case with autologous bone iliac crest, and this is the same case after 7 years. A case with a block of heterologous bovine bone block with the provisional prosthesis, and after 5 years. The results and the complication associated with blocks and the complications associated with implant and prosthesis. The values are not statistically significant. And this is important. Marginal bone loss was similar with the 3 blocks. We are still working. Now, at the start, I said that all techniques work, but I want to explain why I prefer the inlay technique in the posterior mandible. Because I have realized that it is not the quantity of the regenerate bone that is important, but the quality of the bone we regenerated. In particular, the quality of regenerate bone around neck of your implants, especially in the posterior mandible. Look at this case, the only technique. We obtain a perfect regenerative outcomes. You can see there are no gaps and there was no resorption. We removed the screws and prepare the bone course. And look the type of the quality of the bone. And when we prepare the implant sites, we immediately realize that this new bone is not so compact, and we reach a low torque value. This is the X-ray after implantation, and we had no problem. But the question to ask is, how stable will this bone be over time? Look, after 1 year of the loading, we had an important bone loss. What went wrong? Look, after 2 years, after 2 years of the loading, we lost 1 implant. But the literature confirmed this. If you use the only block in the posterior mandible, you have the problem. What we can see about GBR in the posterior mandible? GBR in the posterior mandible, to solve any kind of the atrophy, both vertical and horizontal, and the GBR has the advantages of inserting the implant at the same time as a reconstruction. And when we return to the site 9 months later and remove the membrane, we find this white tissue, the connective layer concealing the regenerate bone. But when you show this video, when you show videos with nice surgeries, you must always ask, how stable will this bone be over time? Because the real problem is long-term stability after vertical bone augmentation, in particular in the posterior mandible. 9 months later, on reopening, and we position the provisional prosthesis. 1 year after loading, what has gone wrong? What happened? What happened? Look here. I have lost more bone. About 2 years, again, what has gone wrong? And look what happened under a year later. What has happened to all the bone we regenerated in the video I showed you before? What happened? I personally think there was one reason. The posterior mandible cannot revascularize the graft materials. Today, studies are being published by GBR experts reporting disappointing results. But why I prefer the inlay technique for the posterior mandible? Because with the inlay technique, we raised the patient native bone block. And the block for this vertical lift is 100% native bone. And when we reopen this site, you cannot distinguish the block of heterologous bone from the patient iron bone. We prepare the histological bone showing the exactly passage between the native bone and regenerate bone. And when we insert the implants and immediately reach high torque lever, so we must unscrew and screw and screw again and unscrew again the implant to avoid stressing the crestal bone, like this video. Why? Because in this case, we have 100% autologous bone from the patient, not reconstructed bone. The final message is only a message, not a scientific dogma. What we see in the daily practice. I prefer the interpositional bone graft technique in the posterior mandible because in this case, with this technique, is predictable. The implant survival is predictable and I have less flap dehiscences. But more long-term follow-up data on the new technique are required. I shall end with this video, and if you look this area, this is the CT scan before the surgery, and this is the nerve, and this is the bone above the alveolar nerve. And dear colleagues, the first thing to do is to decide where to make the total thickness incision with our scalpel. And this is a vestibular incision, and the height of the incision will depend on the position of the mental nerve. In fact, after making the incision, we expose the area to operate and isolate the mental nerve if necessary. And now, with the piece of surgery, we start making the osteotomy line. And in particular, in this technique, you do two vertical osteotomy line, one mesial and one distal vertical osteotomy line, and one horizontal osteotomy line. And pay attention to the lingual periosteum. And after the osteotomies, we can start to see if we can shift the ostomized segment coronally. And like this, and at the end, when you rise the segment, this is the new situation, this is the new space, and look, in this case, rise the coronal segment maybe 5-6 millimeter. And in this space, you decide if you use the particulate or bone blocks. In this particular case, we use the blocks can be cut without water. And when you use the block, at this point you try the block on the patient, and you try and you fix and position it in this new space. And look, this is the new situation. And at the end, I obtain maybe 5-6 millimeter to vertical augmentation. And look, the particulate type of this technique. You remember this block in this case receive the blood with the lingual periosteum, the bone above the nerve, and the blood with the coronal segment. And at the end, this is the beautiful situation for my block or for my particulate graft. And at the end, everything must be fixed with the mini plate. And in this case, the mini plates I use have a diameter maybe 1.2 millimeter. And when I fix everything with the piezo or with a bird like this, model the sharp edge of the block. And if I have any empty spaces, we can use particulate like this. In this case, I use the particulate in the vertical osteotomy. And at the end, lastly, we position the membrane and suture. Now, this is the situation after my intervention. And look, this is the CT scan. And at the end, we obtain this new vertical bone augmentation. Now, normally, when I do this technique, I'm reopening after 4 months. In this case, this is the specific case, because this case is the protocol, is the research protocol at the University of Bologna, and I reopening after only 2 months. And after reopening, it's very incredible the situation of the new block after only 2 months. And look here, I look the clinical aspect only after only 2 months. And I remove the mini screw, I remove the screw, and with the bone core, and I use the burrs, and I do the bone core sample, because at the end, look the quality of the bone, and look the histological situation. I'm not histologist, but what you see in pink is the new bone surrounded by biomaterials. And after only 2 months, we position the implant, and this is the situation before and after within the implant. And this is the, at this point, this is the X-ray with the implant after implant position, and this is the X-ray with provisional prosthesis after 4 months loading, and after 1 year and after 3 years loading. Thank you very much.